all distinguished guests, healthcare professionals, and industry leaders. It is a great honor to be here with you at DDW. On behalf of Dr. Li-Chun Chang and our team led by Professor Wei-Chi Liao from National Taiwan University Hospital, the results of our study entitled Comparison of Adenoma Detection Rate Between Three-Dimensional and Standard Colonoscopy, a multi-center randomized controlled trial. Before we begin, I would like to disclose that this study was supported by Medical Tech MDTK based in Taiwan. However, the study design, data collection, and analysis were conducted independently by our academic team. One of the greatest challenges for colonoscopists is the occurrence of post-colonoscopy colorectal cancer, known as PCCRC. Despite our best efforts, missed lesions continue to pose a significant threat to patient outcomes. First of all, I would like to define the PCCRC. Patients may take CFS for a positive fit or symptoms. The surveillance CFS will be recommended based on the findings at the index CFS. The CRC develops during the surveillance interval is called PCCRC. Where does the PCCRC come from? The study from the Netherlands tells us that PCCRC may come from missed lesion, inadequate surveillance, incomplete treatment, and newly developed lesion. Among these reasons, almost 60% of them is arising from the lesion we overlooked at index CFS. The data from Poland told us the importance of ADR. The lower ADR will lead to higher risk of post-colonoscopy CRC, so-called PCCRC. The data from US also explored the lower ADR lead to higher risk of PCCRC. Moreover, the cancer stage was more advanced in lower ADR group as well. Moreover, CRC was more fetal in lower ADR situation. The data from Poland nationwide screening program revealed that through audit of ADR, the ADR can be improved and the incidence of CRC can be reduced at the same time. Therefore, we can speculate that the incidence of CRC, including PCCRC, can be reduced by improving ADR. However, not all polyps are created equal. While polypoid lesions are relatively easy to detect, flat and depressed lesions, such as types 02A and 02C, are much more challenging. Identifying these subtle morphologies is critical to preventing PCCRC. To improve our ADR, we have to broadly use chromoendoscopy to detection subtle lesions, such as non-polypoid neoplasm. By using chromoendoscopy, we can identify such subtle lesion, such as EH lesion. Detection of flat neoplasms, especially in the proximal colon, is notoriously difficult. Traditional 2D endoscopy often fails to reveal these subtle lesions. So far, more and more studies addressed how to improve the ADR, such as pay more attention and do not rush during withdrawal, improve the bowel cleansing level. With a better cleansing level, we can find more subtle lesion like this. New generation endoscopy, such as wide-angle endoscopy, we can find out more lesion hiding behind the fold. IEE also plays an important role. Both chromoendoscopy and NBI, especially bright NBI, can increase the ADR effectively. As shown in this slide, artificial intelligence has already made significant advances in colonoscopy. Using deep learning models trained on thousands of polyp images, AI systems can now localize polyps in real time with over 96% accuracy. Studies have demonstrated that AI assistants can increase adenoma detection rates by about 20%, as indicated by the pooled meta-analysis results you see here. However, even with AI, certain lesions, especially flat and subtle ones, can still be missed, highlighting that detection challenges persist. In light of these challenges, we explored another complementary approach, three-dimensional colonoscopy. Unlike AI, which aids post-processing or real-time marking, 3D visualization enhances the human endoscopist's ability to perceive depth and subtle mucosal irregularities directly during the procedure. Thus, we hypothesized that 3D colonoscopy could further improve adenoma detection, especially for flat and proximal lesions, beyond what traditional 2D imaging and even AI assistants could achieve. As you can see in this slide, 3D imaging technology has already been successfully adopted in surgical fields, particularly in laparoscopic and minimally invasive surgeries. Surgeons, by wearing polarized 3D glasses and viewing high-resolution 3D monitors, are able to perceive depth and spatial orientation much more accurately than with traditional 2D imaging. The diagram on the right illustrates how separate images are presented to the left and right eyes, creating a vivid three-dimensional effect through parallax. This enhanced depth perception allows for more precise dissection, suturing, and manipulation, improving surgical outcomes and reducing errors. As you can see from this slide, three-dimensional visualization is no longer limited to a few select specialties. It has now become an essential tool across a broad range of surgical disciplines. On the left, you see the application of 3D laparoscopic surgery, where depth perception greatly enhances dissection precision and spatial orientation. On the right, 3D visualization through surgical microscopes has revolutionized fields like ophthalmology and neurosurgery, allowing for safer, more precise microsurgical procedures. And in the center, augmented reality systems are emerging, providing surgeons with real-time 3D overlays during complex interventions, such as cardiac surgeries. All of these advancements share one principle: enhancing the human visual system with three-dimensional perception leads to better decision-making, greater precision, and ultimately, improved clinical outcomes. Given these proven benefits across multiple surgical specialties, we asked a simple but important question: could three-dimensional visualization similarly improve outcomes in colonoscopy, particularly by enhancing adenoma detection? That became the driving question behind our clinical investigation. Building upon the success of 3D technologies in the surgical field, we recognize that gastrointestinal endoscopy presents a unique challenge. Traditionally, endoscopic imaging has been two-dimensional. Medical tech developed an innovative system that enables real-time 3D visualization without altering the fundamental workflow of conventional 2D endoscopy. As shown in this schematic, the process begins by capturing a standard 2D image from a conventional endoscope. Using the intensity of reflected light and sophisticated depth estimation algorithms, the system calculates a depth map for the observed mucosal surface. From this depth information, two slightly different images, corresponding to the left and right eyes, are generated through real-time 3D fusion. The result, displayed via 3D monitors and polarized glasses, is a realistic stereoscopic image that greatly enhances depth perception. Importantly, this entire process happens instantaneously, allowing endoscopists to continue using their familiar techniques while benefiting from enhanced visual information. We would also like to especially acknowledge Professor Wei-Chi Liao. During a local gastroenterology conference in Taiwan, Professor Liao first recognized the potential of medical tech's 3D technology. His visionary insight and clinical perspective were instrumental in bridging this novel imaging technique into real-world endoscopic practice, leading to the initiation of our clinical study. This slide shows Dr. Li-Chun Chang performing three-dimensional colonoscopy at National Taiwan University Hospital, utilizing the medical tech 3D system in a real clinical setting. In the lower photo, you can see Dr. Chang operating the colonoscope while wearing polarized 3D glasses, viewing the mucosal surface in true stereoscopic 3D on the monitors. The two upper images illustrate the difference between viewing with and without 3D glasses. The image on the right is what you would see without wearing 3D glasses, a standard two-dimensional image. On the left, when wearing 3D glasses, the same mucosal surface appears with enhanced depth perception. Admittedly, when viewed through a flat presentation like this slide, it is difficult to appreciate the true three-dimensional effect. However, when viewed directly on a dedicated 3D medical monitor, the depth information becomes vivid and intuitive, significantly improving the operator's spatial awareness during the procedure. This critical insight, that depth perception could be restored and enhanced during colonoscopy, became the driving force behind conducting our clinical trial. We wanted to objectively evaluate whether real-time 3D visualization could meaningfully improve adenoma detection rates compared to conventional 2D colonoscopy. Building upon the promising initial observations, we designed a prospective, randomized, multi-center controlled trial to formally evaluate the impact of three-dimensional colonoscopy on adenoma detection rates. As you can see on this slide, the study was conducted across 3 hospitals within the National Taiwan University Healthcare System: National Taiwan University Hospital Main Campus in Taipei, National Taiwan University Hsinchu Branch, and the NTU Cancer Center. By involving multiple sites within a single medical system, we ensured consistency in colonoscopy quality while enhancing the generalizability of our findings. Patients aged 40 years and older who were scheduled for colonoscopy, whether for screening, post-polypectomy surveillance, or evaluation of symptoms, were eligible for enrollment. Participants were randomly assigned in a 1-to-1 ratio to undergo either standard 2-dimensional colonoscopy or real-time 3-dimensional colonoscopy using the medical tech system. Our primary endpoint was the adenoma detection rate. Secondary endpoints included detection rates of flat adenoma, proximal adenoma, sessile serrated lesions, and polyp detection rates overall, as well as the mean number of adenoma and polyps detected per patient. This slide summarizes the study flow from patient recruitment through analysis. Between February 2022 and June 2023, a total of 348 individuals were assessed for eligibility across the 3 participating hospitals. Of these, 9 subjects declined to undergo colonoscopy, and another 5 subjects withdrew their informed consent after initial enrollment. Consequently, 334 patients proceeded to randomization. Participants were randomized in a 1-to-1 ratio into 2 groups. 167 patients were assigned to the 2-dimensional colonoscopy group, and another 167 patients to the 3-dimensional colonoscopy group. During the course of the study, a small number of patients were excluded due to incomplete cecal intubation or inadequate bowel preparation. 9 patients in total across both groups. Ultimately, 158 patients in the 2D group and 160 patients in the 3D group completed the colonoscopy with satisfactory preparation and were included in the final analysis. This robust flow ensures that the results are based on complete, high-quality colonoscopic examinations, strengthening the validity of the study outcomes. Following the study design and recruitment flow described earlier, here we present the baseline demographic and clinical characteristics of the patients included in our final analysis. As you can see in the table, a total of 158 patients in the 2D colonoscopy group and 160 patients in the 3D colonoscopy group were analyzed. The mean age of participants was comparable between groups, 62.4 years old in the 2D group and 61.4 years old in the 3D group, with no significant difference, p equals 0.40. The proportion of male patients was also similar, 50.0% in the 2D group and 44.4% in the 3D group, p equals 0.32. In terms of colonoscopy indications, there was no significant difference between groups, p equals 0.35, about 28% to 31% of patients were FIT positive, around 28% to 37% were undergoing post-polypectomy surveillance, and approximately 27% to 33% presented with lower gastrointestinal symptoms. Regarding bowel preparation quality, most patients had good or fair preparation. The difference between groups was not statistically significant, p equals 0.085. One notable difference was observed in the total withdrawal time. The 3D group had a slightly longer withdrawal time, 12.5 minutes compared to 11.0 minutes in the 2D group, p equals 0.013. However, when focusing specifically on mucosal inspection time, that is, withdrawal time minus therapeutic intervention time, the difference between groups was not statistically significant, 9.8 minutes for the 3D group versus 9.4 minutes for the 2D group, p equals 0.18. Overall, the 2 groups were well balanced in terms of baseline characteristics, providing a solid foundation for unbiased comparison of outcomes. Moving on to the study outcomes. This slide summarizes the primary and secondary results comparing 2D and 3D colonoscopy. First, our primary outcome, the adenoma detection rate or ADR, was significantly higher in the 3D group, 53.1% in the 3D colonoscopy group compared to 38.6% in the 2D group. This corresponds to an absolute increase of approximately 14.5%, and the difference was statistically significant with a p-value of 0.0094. Looking at the secondary outcomes, several key findings are worth highlighting. First, the flat adenoma detection rate was significantly improved in the 3D group, 35% compared to 21.5% in the 2D group, p equals 0.0076. This is particularly important because flat lesions are historically more difficult to detect and are associated with higher rates of post-colonoscopy cancers. Second, the proximal adenoma detection rate also showed significant enhancement, 38.1% in the 3D group versus 23.4% in the 2D group, p equals 0.0045. Detecting proximal lesions is clinically critical given their higher risk of progression to colorectal cancer. Third, the overall polyp detection rate was significantly higher as well, 62.5% in the 3D group compared to 46.2% in the 2D group, p equals 0.0035. In summary, the use of 3D colonoscopy not only improved the overall adenoma detection rate, but also enhanced the detection of flat lesions, proximal lesions, and polyps in general, all of which are crucial targets for colorectal cancer prevention. To further validate our findings, we performed multivariate logistic regression analysis to identify factors independently associated with adenoma detection. As you can see in this table, several variables were analyzed, including age, sex, BMI, smoking status, family history of colorectal cancer, FIT positivity, and inspection time. On the left side, the unadjusted odds ratios are shown. On the right, the adjusted odds ratios, controlling for confounding factors, are presented. Notably, increased patient age and longer mucosal inspection time were both independently associated with higher ADR, which is consistent with prior studies. Critically, even after adjusting for all these variables, three-dimensional colonoscopy remained independently associated with a significantly higher adenoma detection rate. Specifically, the adjusted odds ratio for 3D colonoscopy versus 2D colonoscopy was 1.83, with a 95% confidence interval of 1.13 to 2.95, and a p-value of 0.014. This result indicates that the improvement in ADR with 3D colonoscopy was not merely due to patient characteristics or procedure time, but was a true independent effect of the 3D visualization technology itself. To summarize, this figure encapsulates the key findings of our study. As shown here, we conducted a multi-center, randomized controlled trial comparing three-dimensional versus standard two-dimensional colonoscopy, enrolling 318 patients aged 40 years and older across 3 institutions. Patients were randomized 1-to-1 into either the 3D or 2D group, and primary and secondary outcomes were rigorously assessed. The bar graph on the right shows that the use of 3D colonoscopy resulted in significant improvements across several critical endpoints. The overall adenoma detection rate, ADR, increased significantly, p equals 0.0094, flat adenoma detection rate was significantly higher, p equals 0.0076, and proximal adenoma detection rate also showed significant improvement, p equals 0.0015. These results confirm that three-dimensional colonoscopy significantly improves adenoma detection, particularly for flat and proximal lesions, areas traditionally associated with higher miss rates and increased risk of post-colonoscopy colorectal cancer. In conclusion, integrating 3D visualization into routine colonoscopy practice may represent a valuable advancement in colorectal cancer prevention. When applying three-dimensional visualization in clinical practice, it is important to understand the underlying display technologies. Among the available options, polarized 3D systems are more commonly used in medical imaging applications, due to their stable visual performance, lightweight glasses, and lower tendency for flickering or eye fatigue. The medical tech system utilized in this study employs polarized 3D technology in combination with medical-grade 3D monitors. Therefore, all procedures conducted in this randomized trial were performed using the polarized 3D format. Each system has its advantages and limitations, and these factors should be considered when selecting a 3D platform for clinical practice. Beyond screening and surveillance colonoscopy, the application of three-dimensional visualization may also hold promise in therapeutic endoscopy. Professor Ken Ohata from NTT Kanto Medical Center in Japan recently published a commentary in Digestive Endoscopy in 2024, discussing the potential benefits of 3D technology during endoscopic submucosal dissection, or ESD procedures. Improved depth perception could theoretically enhance precision during dissection, particularly in complex resections where spatial orientation is critical. Whether 3D visualization can meaningfully assist therapeutic endoscopy remains an open and exciting area for future research. One of the most common questions we encountered during discussions was, if we are already very accustomed to traditional 2D endoscopy, would switching to 3D imaging affect our hand-eye coordination? Or even cause dizziness due to the nature of three-dimensional visualization? This was an important concern, and one that we specifically aimed to address through our study. As shown in this slide, we analyzed both mucosa inspection time and adenoma detection rate over sequential case numbers. What we found was reassuring. After approximately 40 colonoscopies, endoscopists became fully accustomed to the 3D system. Specifically, the mucosa inspection time decreased after about 40 cases, indicating improved efficiency and comfort with the new visualization. At the same time, the adenoma detection rate continued to improve, suggesting that enhanced depth perception could be leveraged effectively once the initial adaptation phase was completed. In conclusion, while a brief learning curve exists, three-dimensional colonoscopy was well tolerated, did not negatively impact procedural performance, and ultimately contributed to better clinical outcomes after a relatively short familiarization period. One question we often receive is whether software-generated 3D imaging causes any noticeable delay. Here, we show a side-by-side comparison. The left screen displays the 3D output from the medical tech system, while the right shows the original 2D endoscopic image. By observing real-time instrument movements and mucosal changes, no significant delay can be detected between the two. In practical use, the 3D processing is effectively instantaneous and does not interfere with hand-eye coordination during procedures. In summary, while our study demonstrates that three-dimensional colonoscopy significantly improves adenoma detection, there are still important areas to explore in the future. First, we need to strengthen the clinical evidence. This includes studying high-risk groups, such as FIT-positive individuals and patients under post-polypectomy surveillance. Conducting multinational randomized trials, performing cost-effectiveness analyses, and understanding the broader impact on colorectal cancer screening programs will be essential. Second, advances in 3D technology continue to evolve. Innovations such as autostereoscopic displays, enabling naked eye 3D viewing without glasses, and the integration of eye-assisted 3D interpretation could further enhance diagnostic accuracy and user experience in the future. Together, these clinical and technological developments will shape the next chapter for 3D colonoscopy. To summarize, here are the key take-home messages. First, 3D colonoscopy significantly improves the adenoma detection rate, or ADR, compared to standard 2D colonoscopy, with detection rates of 38.6% for 2D versus 53.1% for 3D. Importantly, 3D technology particularly enhances the identification of flat and proximal adenoma, which are often more difficult to detect. Second, the learning curve for 3D colonoscopy is short, meaning that practitioners can quickly adapt to using the system without extensive retraining. Third, there is no noticeable time lag when using the 3D system, allowing for smooth, real-time operation during procedures. Finally, for future directions, we are planning to focus on three key areas: applying 3D colonoscopy to high-risk patient groups, conducting multinational trials to further validate our findings, and promoting broader adoption through targeted education and training programs. Thank you for your attention.